We're very lucky today to have Dr. Tatyana Kushner for her grand rounds on viral hepatitis in pregnancy. Dr. Kushner graduated from medical school here at Mount Sinai and then stayed on to do her internal medicine residency here before moving on to do her subspecialty fellowship in gastroenterology at University of Pennsylvania, where she also received a master's in clinical epidemiology. She then went on to complete a hepatology fellowship at UCSF before coming back here to join us again at Mount Sinai. Dr. Kushner's research interests are in viral hepatitis management and diagnosis during pregnancy, and it's in this field that she's had multiple publications in large peer-reviewed journals. So we're very lucky to have Dr. Kushner here. Please give me a warm welcome, Dr. Kushner.
Well, thank you very much to Dr. Murphy, Dr. Thomas, the chief residents, for the invitation to present here today at Grand Rounds. It's really, truly an honor to be here. I remember, to me at least, it doesn't seem very long ago at all that I was a medical student and resident in this audience, just thinking about how I could possibly have any impact on medicine or liver disease. And I think largely due to the mentorship I've had here and throughout my training, I've really identified this field of women's health and liver disease and pregnancy-specific liver disease as a field where I truly feel like there's work to be done and is a very important field. So today I'll be talking about hepatitis B and hepatitis C during pregnancy. And why do I think this is important? Well, I think pregnancy is actually oftentimes the first time that women encounter the healthcare system. And so this is really a time that we can initially diagnose viral hepatitis as well as other liver diseases and otherwise. Also, it's a time of high impact. We're, of course, dealing with mother and child. So if we're talking about big plans for viral elimination, it's really a time of very high impact. And then finally, as we'll see towards the end of the presentation, there's really still some controversy in the field in terms of approach to management of hepatitis during pregnancy. And I think that's interesting because there's still unanswered questions. These are my disclosures. So to start with a broad look at viral hepatitis in the world, so it's a big burden of disease in the world. It's really a leading cause of death worldwide. In 2013, there were almost 1.5 million deaths from viral hepatitis, surpassing that of HIV, malaria, tuberculosis. So quite prevalent worldwide with a high burden of disease. And over 90% of these deaths from viral hepatitis were from hepatitis B and hepatitis C. And this was so big that, in 2014, actually, the World Health Assembly requested the World Health Organization to examine the feasibility of a huge campaign to eliminate hepatitis B and hepatitis C as a public threat. And so in 2016, the first ever global health sector strategy on viral hepatitis was developed. And they had a global vision and a goal. The global vision was a world where viral hepatitis transmission is halted and everyone living with viral hepatitis has access to safe, affordable, and effective prevention, care, and treatment services. And the goal is to eliminate viral hepatitis as a major public threat by 2030. So that's a little over 10 years away from today, so we have a lot of work to do, internationally as well as in our own country. So in this campaign, there are 5 core viral hepatitis interventions that were thought to be important. The first was vaccination for hepatitis. The second was injection, blood, and surgical safety and universal precautions. The third was prevention of mother-to-child transmission. Fourth was harm reductions for persons who inject drugs. And the fifth was treatment of chronic hepatitis B and hepatitis C, and importantly, access to treatment for chronic hepatitis B and hepatitis C. And I would say at least 3 of these, if not more, are quite relevant to care that we provide to women during pregnancy, which is why pregnancy becomes an opportunity to address many of these goals. So what are the issues? What's special about viral hepatitis, and specifically hepatitis B and hepatitis C during pregnancy, and what do we really need to think about when dealing with women who are pregnant with viral hepatitis? The first is the changing epidemiology. So I'll focus mostly on the United States, and we'll see that over the recent years, there's been an increase in hepatitis among women of childbearing age, which of course means an increase among women during pregnancy. And so with an increase, that should impact our guidelines and recommendations for management during pregnancy. We need to also think about the effect of pregnancy on the virus. So does pregnancy impact the viral activity and the progression of viral hepatitis? And then conversely, we need to think about the effect of the virus on pregnancy. Does having viral hepatitis during pregnancy negatively impact pregnancy outcomes? We need to, very importantly, think about mother-to-child transmission. Does it occur? How frequently does it occur? And are there any methods to prevent or decrease any risk of mother-to-child transmission? And then finally, penultimately, we need to think about screening during pregnancy. Is pregnancy an important time to screen for viral hepatitis? And lastly, about antiviral therapy options. So treatment of viral hepatitis and the role of antiviral therapy in particular during pregnancy. So I'll start by talking about hepatitis B. I think that even though the treatments we have for hepatitis C have surpassed those that we have for hepatitis B in the sense that we have actually a cure for hepatitis C, which we really don't for hepatitis B, I think the guidelines that we have available for hepatitis B, specifically for pregnancy, are far ahead of those that we have for hepatitis C. So I'll start with hepatitis B. So in general, hepatitis B in the world is actually quite prevalent, with 30% of the world's population with any serologic evidence of hepatitis B exposure. Again, the United States is considered a low prevalence country, but keep in mind that more than 80% of the world has intermediate to high prevalence of hepatitis B. So that means ranging from 2 to 8% of the population in those countries affected by hepatitis B. In the United States, there have been several evaluations of the true prevalence of hepatitis B in the US. And on the left here is data from the National Health and Nutrition Examination Survey, which surveys a subset of Americans to look at prevalence of infection, among other things. And the NHANES data suggested that there are about 850,000 Americans who have chronic hepatitis B infection, but it's quite clear that this is definitely an underestimate because the NHANES does not include data from institutionalized patients and incarcerated patients, and so the likely estimate is probably closer to 2.2 million of Americans living with hepatitis B. And very importantly, up to 95% of the patients that we see with hepatitis B in the United States are immigrants. So most of the patients that we see here are immigrants, specifically from Asia and Africa. On the right here, this is a study that looked at trends over time in hepatitis B, and specifically it looked at US rate of infection, so people who are born and citizens of the US compared to the imported rate of infection, which is in the red line. And we see that around 1991, there has really been a significant and impressive decline in the US rate of hepatitis B infection. And that's because in 1991, there was a big campaign to eliminate hepatitis B in the United States, which included universal immunization to all babies born in the United States, as well as other features such as screening, increased screening. And so we see that the US rate has really declined starting around that time, but the imported rate really hasn't felt this impact. And that's probably because the campaign that we had here in the United States has not been seen around the world. And so as a result, we still see very many immigrants in the United States who have hepatitis B as adults. And then more recently, there's been a look at this again, and this is really in the setting of this new, or not so new anymore, opioid epidemic. And so the CDC uses the National Notifiable Disease Surveillance System, which reports new infections, and they specifically looked at 3 states actually, Kentucky, Tennessee, and Virginia. And these are states that are in the Appalachian region and have been very strongly impacted by the opioid epidemic and high hepatitis C rates. So they decided to do an enhanced surveillance. And actually what they did find is that they did see a more than 100% increase in acute hepatitis B over time from 2006 to 2013, which occurred predominantly in non-urban settings among whites who reported injecting drugs who were ages predominantly 30 to 39. So this suggests that, yes, this is a relatively small study and just looking at 3 specific states, but that the opioid epidemic, injecting drugs, and associated high-risk sexual behaviors are also potentially increasing the rates of hepatitis B in the United States. We decided to look at this specifically in women of childbearing age to see if women of childbearing age are impacted, and we actually used the National Quest Laboratory database from 2011 to 2017, where we had results of hepatitis B testing in over 8 million women aged 15 to 44 or childbearing age, and we assessed for rates over time of hepatitis B in women in particular. We also looked at rates in children, and what we found is similar here. We saw that nationally speaking, from 2011 to 2017, the rates of chronic hepatitis B have been actually declining, and acute hepatitis B has remained relatively stable. That's the dotted line that you see here. But then we did see a few states that had opposing increases in rates of chronic and acute hepatitis B, and these states included states such as Kentucky and West Virginia, which again are located in this Appalachian region, which is very impacted by the opioid epidemic. Of course, this is an indirect assessment of it, but it really does suggest that these young people who are injecting drugs are also at risk for acquiring hepatitis B, potentially even despite vaccination at birth. So what are we doing for screening during pregnancy for hepatitis B? Well, initially in the 1980s and 1984, high-risk screening was recommended for hepatitis B during pregnancy. That means women who endorsed risks of injecting drugs, history of dialysis, blood transfusions. And very soon after that, it was found that this high-risk screening was really ineffective in actually identifying all women with hepatitis B. And so in 1991, actually, as part of this big campaign to eliminate hepatitis B in the United States, universal screening was recommended during pregnancy. And still, to date, the recommendation is to screen all women for hepatitis B during pregnancy. Since that time, there have been several studies and evaluations over time to look at rates of hepatitis B, and not surprisingly, both the National Perinatal Hepatitis B Prevention Program and also an assessment of the nationwide inpatient sample have found increased detection of hepatitis B over time. Of course, this probably is a reflection of universal screening, but also can reflect increased prevalence of hepatitis B among pregnant women over time. And then in regards to the effect of pregnancy on hepatitis B, we know that hepatitis B is a very immune-responsive virus, and there are significant immune changes during pregnancy, such that women during pregnancy are relatively immunosuppressed, but then after pregnancy, there's a period of immune reconstitution or immune restoration. And the thought is that this is a time when hepatitis B flares can occur, and when they occur, they can potentially lead to liver decompensation. This issue has now been looked at actually by multiple studies in the United States, as well as Asia, Netherlands, Australia, to look at what is truly the prevalence of these hepatitis B flares and when do they occur. And importantly, in all of these studies, the definition for hepatitis B flare differed, and also they evaluated both postpartum and intrapartum flares. And generally speaking, they found a range of anywhere from around 10% to 50% of occurrence of these flares defined by elevated ALT. And they found higher rates of flares in those who had early antiviral therapy cessation after pregnancy. But importantly, most of these flares that were described across these studies were subclinical, meaning that the ALT flared after pregnancy and then got better on its own, and very few patients actually had significant hepatic decompensation. So given that, really the important thing to know is that the ALT can flare after pregnancy, and women should be monitored, especially in the setting of discontinuing antiviral therapy after pregnancy, but fortunately few will develop significant disease. And then the effect of hepatitis B on pregnancy outcomes. So this has been also evaluated in large population-based studies and retrospective studies to look at whether hepatitis B actually impacts pregnancy negatively. So there's a large population-based cohort in China of over 400,000 women, and they looked at the risk of preterm birth and found a slightly increased relative risk of preterm birth in women with hepatitis B compared to non. There's been a study, a large retrospective study in Thailand looking at risk of gestational diabetes. They found an association of women with hepatitis B with gestational diabetes, specifically if they were E antigen positive. So again, possible association as well with low birth weight, and a recent study that actually identified that infants who are co-infected with HIV, if they have hepatitis B, they're more likely to actually transmit the HIV virus through mother-to-child transmission. So I think in regards to these types of studies, most of them are largely association studies. It's difficult. I have not been ready to kind of counsel women to say, oh, you have hepatitis B and you'll be at risk for these negative pregnancy outcomes, because I really think they need to be validated with larger prospective studies. But definitely there are some suggestions of an association with negative pregnancy outcomes. In regards to mother-to-child transmission of hepatitis B, it's quite transmissible. Hepatitis B is very transmissible. So specifically in women who are E antigen positive, without intervention, there's a 90% risk of transmission to the baby. If they're E antigen negative, which is associated with lower viral loads, then transmission risk is much lower. The timing of transmission, we always think about can occur intrauterine, can occur perinatal and postnatally, in particular during breastfeeding. But for hepatitis B, the thought is that most of transmission happens at or around the time of birth, which is why early hepatitis B vaccine and immunoglobulin around the time of birth is extremely important. Perinatal transmission still accounts for a really large portion of the global burden of hepatitis B, and that's because if babies acquire hepatitis B through mother-to-child transmission, then 90% of them will go on to develop chronic disease. In contrast to adults, if adults are exposed to hepatitis B, the vast majority of them will clear. And so that explains why many of the patients we still see are patients who had transmission through vertical transmission. And when transmitted during birth, 15 to 25% of these children will have premature death from liver-related complications. So it's very, very important to decrease risk of transmission. And that's why it's excellent that we have both the hepatitis B vaccine, which was developed in the 1980s, as well as hepatitis B immunoglobulin, which was around since before then, that we administer at birth to the infant, and it's 85 to 95% effective in decreasing the risk of transmission. How about antiviral therapy? So what antiviral therapy options do we have for hepatitis B in general? Well, there really aren't many, actually. So it's pretty simple to treat hepatitis B because our options are really very few. So basically what we choose from is either entecavir or tenofovir-based regimens, which are both nucleoside reverse transcriptase inhibitors. And then we also have pegylated interferon available, but due to association with significant side effects, we very rarely actually use that for hepatitis B. And really, these are the preferred agents because they're very potent in suppressing the hepatitis B viral load, and they have high barriers to resistance. And then when it comes to pregnancy, it's even simpler. There's really only one recommended agent, and that's tenofovir disoproxil fumarate. And the reason is that it's been really very well studied in HIV patients and hepatitis B patients, and has been well found to be safe to use during pregnancy. And when do we use antiviral therapy for hepatitis B in general? Well, we know that the higher the viral load, the higher the risk of complications from hepatitis B. And so this is the REVEAL study. This is kind of the landmark study for hepatitis B natural history, where about 4,000 patients in Taiwan were followed over time, and they started follow-up with different viral load cutoffs. And what we see here is that as the initial viral load increases, there's an increased cumulative risk, and this is a median 12-year follow-up. There's an increased cumulative risk of liver cancer as well as cirrhosis. So we know that higher viral load is really what leads to poor outcomes. And therefore, these are our guidelines, which very simply, this doesn't look so simple, but it actually is. Very simply, we just look at patients' viral load. If they're elevated over 20,000 in E antigen positive patients or over 2,000 in E antigen negative patients, we initiate antiviral therapy if they also have a mildly elevated ALT. How about pregnancy? So in pregnancy, we treat women if they meet criteria for treatment otherwise, if they were not pregnant. But of course, we use tenofovir because that's the recommended choice of therapy. And then we also have learned that high viral load during pregnancy can increase the risk of mother-to-child transmission despite administration of vaccine and immunoglobulin. So these are two studies demonstrating an increased risk of mother-to-child transmission or prophylaxis failure in women who have progressively increasing hepatitis B DNA levels during pregnancy. This was a randomized trial conducted by Calvin Pan and published in New England Journal in 2016, which actually randomized women specifically with these high viral loads to either receive tenofovir or not during third trimester. And they found in both their per protocol analysis as well as the intention to treat analysis that there was a significant increase in infants with hepatitis B infection in the control group compared to the tenofovir group, demonstrating the benefit of antiviral therapy during third trimester in highly viremic patients. Subsequent to that, in 2018, there was another study from Thailand published in the New England Journal, which actually raised some controversy because in these results, there was no statistically significant difference in transmission rates in women who received tenofovir versus women who didn't. However, when we look closely, there is a numerically different rate of transmission, 3 in the placebo group versus 0. And the thought was that the reason that there was so little transmission in general here is that in this study, the median time to receive hepatitis B vaccine and immunoglobulin was 1 hour from birth, which is not necessarily practical or implemented broadly. And so therefore, it may have been kind of underpowered and also may have their specific practices at their particular hospitals were probably different than many others. And so despite these studies, the guidelines still stand that both the Liver Society as well as the OB Society, the Society for Maternal Fetal Medicine, both agree that women with high viral loads need to be treated with antiviral therapy during third trimester to prevent transmission. This is a schematic that we put together about treatment in general, and basically we ask 3 questions. The first, when we see a woman who's pregnant with hepatitis B, so we ask, does she qualify for hepatitis B treatment prior to pregnancy? If she does, then we continue her on treatment, and if she's not taking tenofovir, we switch her to tenofovir. If she doesn't qualify for treatment at the beginning of pregnancy, then we check viral load at third trimester. If it's elevated over 200,000, then we initiate antiviral therapy. And in that context, you can actually discontinue at pregnancy delivery, although very importantly, these women need to be monitored for flares, specifically after antiviral therapy discontinuation. And are we actually following these care recommendations in US settings? So during my time in Philadelphia, we did a study in southeastern Pennsylvania looking at 4 major medical centers and retrospectively evaluated 310 women with 388 pregnancies. And what we found is that in only 29% of them, hepatitis B DNA was actually ever measured during pregnancy. Among those who met this viral load cutoff for treatment, only 38% had hepatitis B treatment initiated. And then importantly, out of all these patients, only 50% had any evidence of a referral to a specialist in their chart, suggesting that many women after their pregnancy care are kind of lost to follow-up, and hepatitis B is a chronic disease without a cure. So it's important to make sure that they are linked to care. So we developed a care cascade, which includes obviously screening for hepatitis B during pregnancy, referral to a liver specialist or infectious disease specialist, testing the viral load, and treating if criteria are met, with ultimate goal of decreasing or completely eliminating any risk of mother-to-child transmission in the US, as well as linking to care. And I think using pregnancy then as an opportunity to help decrease hepatitis B further in the United States. Currently, what we're doing is we're evaluating gaps in care in New York City, Philadelphia, and San Francisco in kind of high and low prevalence US settings to try to identify patient and provider predictors of care, and also to assess secular trends of adherence to guidelines since time from guideline implementation has passed. And finally, to see if tools such as clinical decision support can help to assist in improving these gaps in care. So to summarize hepatitis B, the US is considered a low prevalence hepatitis B country, but the majority of hepatitis B that we see here is in immigrants. And also, it may be on the rise. There's a few studies now pointing to the fact that it may be on the rise due to the opioid epidemic. I think pregnancy really provides an excellent opportunity to diagnose hepatitis B and initiate treatment in those that qualify. And then mother-to-child transmission is very high with hepatitis B, but we really have the tools to prevent it with passive and active immunization, as well as antiviral therapy in those that qualify. And finally, I think addressing gaps in pregnancy hepatitis B care is critical in order to really work towards viral elimination with that 2030 goal in mind. So now shifting to hepatitis C during pregnancy, this is where all the controversy is. So hepatitis C in the world, it's about 1% world prevalence, although there are some countries, such as Egypt, with up to 15% prevalence of hepatitis C in the country. In the United States, an estimated 3.5 million cases of chronic hepatitis C, and many of them are in women of childbearing age. Here we see that starting in around 2009, there's been really an increase among both males and females of acute hepatitis C being reported. And again, predominantly this kind of recurring theme of occurring in non-metropolitan areas compared to metropolitan areas among whites. And we see that the age group affected by hepatitis C has shifted. So in the early 2000s, the leading age group for hepatitis C was really the baby boomers, which is why the USPSTF recommended screening for all baby boomers, because that's where it was the most prevalent. So this is age 40 to 49. However, you see there's a shift starting around 2009, 2010, and now the highest incidence is in the young age group, the 20 to 29 age group. And why is this happening? Again, this really emerging epidemic of hepatitis C among heroin users. So this study looked at rates of reported cases of hepatitis C from 2006 to 2012, and you see the increase red on the US map, which of course varies by state and county, but a substantial increase over time with a 13% annual increase in the rural areas and 5% annual increase in urban areas. And this coincided perfectly with regional doubling of first-time heroin users. 3 out of 4 of the patients with hepatitis C had a history of prescription opioid abuse that then transitioned to injecting, and 97% of them initiated drug use before age 20. So this is really a serious problem, particularly among young people. This is data from the New York State, and we see again in 2005 there was really one peak of new hepatitis C reported between 40 and 60 years of age, and then gradually in 2012 we see a second peak emerging in 2015 and 2016, where we see the second peak among younger people, which of course includes reproductive aged women. This is a study that looked in particular at women of childbearing age and used Quest data and again CDC data. And we see again, starting in 2012, 2013, that hepatitis C among women aged 15 to 44 began to surpass hepatitis C in women aged 45 to 64 in the dotted line. There's some data to suggest that incidence of hepatitis C may be higher in women than men who inject drugs. So this is a systematic review that looked at studies from across the world and found that overall women were 36% more likely to be, women who inject drugs were 36% more likely to be hepatitis C positive than men. And several reasons were proposed for these. One is that women who inject drugs have been shown to have higher incidence of HIV and injection-related risk behaviors, so they're at higher risk of, therefore, contracting hepatitis C, more likely than males to have injection drug-using sexual partners, and also females may be more likely to face stigma, and so maybe less likely to participate in harm reduction services. So women who inject drugs may be at higher risk for acquiring hepatitis C. When we look specifically during pregnancy, this is data from the nationwide inpatient sample, and we have a comparison here of HIV, hepatitis B, and hepatitis C over time. And we see that hepatitis C is really increasing the most rapidly. This is from 1998 to 2011, with a 5 times increase during those years. This is another more recent study report in 2017, which looked at hepatitis C reported at pregnancy delivery and found an 89% increase from 2009 to 2014 of the number of hepatitis C cases reported during pregnancy care. Of course, we see substantial variability in terms of regions and states and even counties within states. So in Tennessee, there was several counties that had an 8% rate of hepatitis C among all pregnant women. But it's quite striking that we're seeing so much more of it than we did. Interestingly, also in this study, they found that women with hepatitis C were 4.5 times more likely to be smokers. So these are women with risky health behaviors in general, and also 17-fold higher, more likely to have hepatitis B, again suggesting shared risk factors of injection drug use and associated sexual behaviors for contracting hepatitis C and hepatitis B. This is another study looking at birth certificate data, again showing increase from 2011 to 2016 in pregnant women who are hepatitis C positive. And mostly they were seeing this in age 20 to 29, white non-Hispanic women who are covered by Medicaid and had rural residences. So given this increase, what is the recommendation for screening for hepatitis C during pregnancy? So, in hepatitis B, we have universal screening. And for hepatitis C, most of the societies, including CDC and the obstetric societies, recommend risk-based screening. So again, this includes women who report any of these listed risks, such as injection drug use, dialysis, history of incarceration, receipt of unregulated tattoos, and other risks. So how about universal hepatitis C screening during pregnancy? Is there a role for universal screening, same as what we do for hepatitis B? And this is where part of the controversy is, because there's really disagreement between hepatologists and obstetricians and even within the fields. So what would be the benefit of doing hepatitis C screening during pregnancy? Well, we know, such as what we learned in hepatitis B, that risk-based screening is problematic, that especially during pregnancy, women are likely to underreport their risk factors. Risk-based screening, some would say, is outdated. We no longer just have interferon and ribavirin for treatment of hepatitis C, so is there potentially a role for treatment during pregnancy? It's operationally simplest to do universal screening, if you could just screen everyone, as opposed to dedicating the time and resources for a good risk assessment. And of course, with universal screening, we would identify the most hepatitis C infected women. The cons, or the reasons to not do universal screening, is currently there are really no existing measures to prevent or reduce the risk of transmission. So in hepatitis B, we have the vaccine, we have the immunoglobulin. We don't have that for hepatitis C. Direct-acting antiviral agents are not approved for use during pregnancy. And then there's a risk of a false positive rate, which would cause undue worry for expectant mothers. And of course, there are costs associated with performing universal screening. And hepatitis C is not a pregnancy-specific disease, so why would we screen during pregnancy? And a relatively low transmission risk, as we'll see. So actually, just recently, there was one of 2 cost-effectiveness analyses performed. And actually, it did demonstrate that even in the lowest prevalence regions, like 0.07%, which is Hawaii, the lowest prevalence of hepatitis C, it was actually found to be cost-effective to do universal screening. And in the study, they estimated that with universal screening, 33,000 women and 300 children would be newly diagnosed with hepatitis C if we had universal screening compared to risk-based. Also, there's a recent study that suggests that, similar to hepatitis B, risk-based screening doesn't work in hepatitis C. So in this study of over 1,000 pregnancies, among women with any hepatitis C risk factor, only 64% of them were not actually tested for hepatitis C. And then 10% of the women who were found to be hepatitis C positive had no reported risk factors. So again, risk-based screening is not identifying all of the women with the disease. So actually, the Liver Society and the Infectious Disease Society have recently given the changing epidemiology and importance of this, have changed their recommendations to recommend universal screening for hepatitis C during pregnancy. That was in May of 2018. But unfortunately, given that the other societies are still not on board, this has not been broadly implemented, although we are doing it here at Mount Sinai and have been doing universal screening during pregnancy now for over a year. So in regards to the impact of hepatitis C on pregnancy, again, similar to hepatitis B, there are these large association studies and registry studies that have found an association with preterm birth, intrauterine growth restriction, and low birth weight, as well as late neonatal death. And these studies do a good job to try to adjust for the potential confounders. They adjust for smoking, they adjust for parity. The Swedish Birth Registry adjusted even for education level. But again, with these large association studies, it's difficult really to measure all the confounders that would be associated with both hepatitis C and these negative pregnancy outcomes. And so again, I think this needs to be prospectively validated, and there is actually a large observational study going on in the United States currently to look at outcomes in hepatitis C positive pregnant women and their infants. There is a pretty strong association now established with cholestasis of pregnancy. So cholestasis of pregnancy is the itching disease of pregnancy. It's a pregnancy-specific liver disease that's actually also associated with negative fetal outcomes. And in a meta-analysis of ICP, or cholestasis of pregnancy studies, there was a pooled odds ratio of 20 times more likely women with hepatitis C compared to not of having cholestasis of pregnancy. So we do counsel women with hepatitis C that they may be at risk for cholestasis and to monitor for these symptoms during pregnancy. In regards to the effect of pregnancy on hepatitis C, in hepatitis B, we saw this issue of flares that are associated with pregnancy. With hepatitis C, there may be some increase in hepatitis C RNA during pregnancy and some fluctuation of liver test aminotransferase levels during pregnancy and postpartum. But I'm not sure if there's a huge clinical significance to this. There's even one study that suggested that there may be significant worsening of fibrosis or histological disease, but then other studies that did not say that. So I think in terms of the effect of pregnancy on hepatitis C disease course, I think we monitor them, of course, but unclear if it has really a significant impact. And finally, mother-to-child transmission of hepatitis C. So this is a systematic review of over 100 studies looking at hepatitis C positive RNA positive mothers to look at risk of transmission. And generally speaking, the risk of transmission is about 6% from mother to child. But then if they're co-infected also with HIV, that risk significantly increases up to 10.8%. And in one study, even up to 30% of risk of transmission of hepatitis C in women who are co-infected with HIV. The timing of transmission is not very well known, although it's thought to be predominantly in the peripartum period. This was a small study from the European Pediatric Hepatitis C Network, where they looked at 54 infants who were infected with hepatitis C and were tested at 3 days or less after birth and then subsequently. And they found that 17 of them had early detection of HCV RNA, suggesting that transmission happened earlier intrauterine. But then the rest had appearance of the RNA later on at 3 months and 6 months, suggesting that probably the transmission occurred at around the time of delivery and therefore happened later. The recommendation now from the guidelines is to test infants born to hepatitis C mothers actually at 18 months for hepatitis C antibody. And because prior to that, there's passive transfer of the maternal antibody. So the recommendation is really to bring back the infant not for early hepatitis C RNA testing, but for antibody at 18 months to definitively know. But is this really being done? So this is a study from the Philadelphia Department of Health, and they had almost 600 women with hepatitis C who had infants, and out of those, only 16% of the children were ever tested for hepatitis C. So it's difficult to expect for pediatricians to test 18 months later unless the mother is really very informed and actually goes to the pediatrician to say, I want my child tested. Are there any ways to prevent transmission during pregnancy? So in terms of pregnancy management, C-section versus vaginal delivery have been compared in a number of studies. Some have shown benefit to C-section, but pooling all these studies together, there really has been no significant decrease in risk of transmission in delivery type. There is an association of increased transmission possibly, but not with great evidence for invasive fetal monitoring and then prolonged rupture of membranes. So women should be counseled that they may be at increased risk, and obstetric management should take this into consideration, but there's not too much that can be done if these measures are necessary. And finally, there's not a significant risk of transmission with breastfeeding. In regards to the impact on children, so mother-to-child transmission is the most common cause of hepatitis C infection in children. 25 to 40% of infants will luckily clear hepatitis C on their own by 2 to 3 years. But there is an impact on children that may be extrahepatic as well. There are several studies pointing to reduced quality of life in children as well as their caregivers, the caregivers of children with hepatitis C. There's also a recent study showing that there are higher rates of cirrhosis in children who acquire hepatitis C through mother-to-child transmission compared to other methods during childhood. And liver cancer, hepatocellular carcinoma, is the second most common hepatic malignancy in children, and so hepatitis C is clearly contributing to this as well. The current recommendations for treatment in children, so this is AASLD, our liver society. The recommendation is to treat children when they're 12 years of age or older. We currently do not have approved treatments for children under 12. So if they do acquire hepatitis C through transmission, they're waiting 12 years to be treated. And what antiviral therapy options do we have for hepatitis C? Well, as many of us are aware, there's really been a revolution of hepatitis C treatment over the years. So we started with interferon, then we developed ribavirin and pegylated interferon, and over time, these directly acting antiviral therapies, really an explosion of new therapies available that started around in 2011 with the first generation directly acting antiviral agents. And quite impressively, the rate of cure is really almost perfect. So we started off with hoping for about a 40% cure with interferon and ribavirin, and now more than a 95% chance of cure of even the most complex patients with third-generation directly antiviral agents. This is really a success of modern medicine and really quite impressive. And so these are really our antiviral therapy options of choice, and as you can see, many of them are pan-genotypic, meaning they work for every genotype of virus. We don't even have to worry about what genotype they have anymore. And most of them are effective for cure in 8 to 12 weeks of therapy. So quite easy and to use. So how about antiviral therapy during pregnancy? So again, pros and cons. There are no universal recommendations. In fact, most would argue against it. Pros, I think, prevention of maternal disease, curing the mom when she's actually engaged in her own care during pregnancy, prevention of perinatal transmission potentially, decrease in community transmission of hepatitis C, and opportunity to cure prior to the next pregnancy and prior to the next, placing the next infant at risk of mother-to-child transmission. The cons are that we don't have a lot of safety data on these new medications. DAAs are expensive and potentially difficult to access efficiently during pregnancy, and many would say that women should just be treated before they become pregnant, or you can treat their hepatitis C in children later when they turn 12 years old, and hopefully we'll have treatment available for younger age groups soon. So what does the AASLD, the Liver Society, and the Infectious Disease Society say about treatment using these DAAs, directly antiviral therapy agents, for treatment during pregnancy? Well, they say for women of reproductive age with known hepatitis C infection, antiviral therapy is recommended before considering pregnancy. And they have a red box warning that says treatment during pregnancy is not recommended due to the lack of safety and efficacy. Red box warning. However, Dr. Dietrich was very forward-thinking about this, and he published this in 2015 in Hepatology, and at that time looking at the currently available DAAs that we had, including Harvoni, and many of these, based on animal data and the safety data that we had, were a pregnancy category B, which is actually many of the medications that we use during pregnancy are considered safe if they're pregnancy category B. In San Francisco, we did a survey of women actually with hepatitis C at UCSF and the Women's Interagency HIV study. Many of these women were co-infected with HIV, and we asked them, would you consider treatment during pregnancy? And 60% of them said, or the majority said, that they would take directly antiviral agents if it lowered any risk of mother-to-child transmission. And actually, just recently, last month, the first study of treatment during pregnancy was presented at the Infectious Disease Conference. This was a phase 1 study of lodipisphere sofosbuvir in pregnant women with hepatitis C, with the primary objective to define the safety and virologic response to Harvoni in pregnancy. And as you can imagine, this is a difficult patient population, difficult to recruit, difficult to retain. So they screened 29 patients and ended up enrolling 9 patients, which even that was viewed as a success. Part of the reason is that Harvoni is not, you can't use Harvoni for genotype 3 infection, and many injection drug users do have genotype 3. But of these patients that completed, all of them achieved SVR, or sustained virologic response, cure of their hepatitis C. And there were really few maternal adverse events. So I think I know there will be further studies of treatment during pregnancy, and I think that over the years that our guidelines will shift to consider the use of antiviral therapy during pregnancy. So to summarize, Hepatitis C in women of childbearing age is really on the rise in our country as a result of the opioid epidemic, and therefore we're diagnosing more women with hepatitis C during pregnancy. Universal screening for hepatitis C is recommended by the Liver Society and can identify more patients with hepatitis C and link them to care, but currently there are no approved ways to prevent mother-to-child transmission of hepatitis C, and I think that treatment during pregnancy will continue to be investigated. Here at Mount Sinai, we also have a women's liver clinic to try to help with this linkage to care and retention of these patients. And this was started in September of 2017 with the support of Dr. Dietrich and Dr. Sperling. And we see women with liver disease co-located in the obstetrics department. And so far, we've seen over 100 patients, 40% of them with hepatitis C, 38% of them with hepatitis B, really with the goal of capturing these patients and treating them and linking them to ongoing liver care, especially for hepatitis B, for example, which is a chronic disease, and they'll need ongoing management. So to conclude, overall, pregnancy is, I think, a really important time when we think about viral elimination. It's time for universal screening for hepatitis B and prevention for mother-to-child transmission. We have the tools to prevent transmission for hepatitis B. For hepatitis C, as you've seen, there are really no uniform guidelines for screening or for treatment during pregnancy, but I think that's why this field is very exciting, because right now is the time that we're beginning to do more studies on this and understand how that will shape guidelines. And finally, I think addressing viral hepatitis during pregnancy is really an opportune time to diagnose, treat, and link to care for ongoing management of chronic liver disease. I would like to thank my mentors, Dr. Dietrich, who really actually inspired me to pursue a career in liver disease in the first place back when I was a resident. Dr. Sperling from OB, who has really helped me build this niche in pregnancy-related liver disease. Dr. Bansell, Dr. Friedman, who have been very supportive in research and otherwise. And then my mentors at UCSF and UPenn, and of course the support of the AASLD Career Development Award. And I'd like to thank everyone in the liver department who make it fun to come to work and treat patients with liver disease every day. Thank you.
Questions for Dr. Kushner? Two-part question. The first is, you implied that the second virus, I need to say, after Hep C, I guess, there's new Hep B. I forget the alphabet there, but there was one chronic virus and then another virus was found, correct? You did say that.
In terms of discovery of the virus, or?
Well, people with Hep C seem to be
co-infected with hepatitis B?
Yeah, that's my question.
Yeah.
They probably are co-infected, but I have a question for you. Do you or others study the possibility that there's a transformation within virus C and it becomes B?
No. No, I mean, they're pretty distinct viruses with kind of distinct structure and viral life cycles. I think it's quite possible to see both of them in the same person because they're acquired through really very similar risk factors. Hepatitis B happens to be much more transmissible than hepatitis C, but in terms of conversion from one to another, they're pretty distinct.
Your age-specific incidence curves for hepatitis B appeared to show a second peak in the older age. Was that correct, and if so, why?
You know, I think that if we see it in the older age, it may reflect the fact that they didn't benefit from birth dose vaccination. So if they were born prior to 1991, you know, they're older now, and so therefore they may not have benefited from birth dose vaccination, so therefore may be more at risk for hepatitis B.
That's another argument for universal screening for hepatitis B.
Yes, agreed.
So you mentioned that pregnancy is an immunosuppressive disease in a sense, but if it weren't true, this auditorium would be empty. Nobody would be born.
Right.
So it brings up a question then about vaccination for hepatitis B. Is the titer raised by the vaccine the same if you're pregnant and if you're not pregnant? And number two, does the length of time that the titer of the antibody persists, is that changed according to whether you're vaccinated during pregnancy or not?
Yeah, those are good questions. So, you know, we do recommend for previously unvaccinated women at risk for hepatitis B to get vaccination at birth. And so, you know, we think that it's as effective. We don't routinely do serologic testing after vaccination in adults. We do that in children. So, you know, it's hard to, I don't know that there are any studies that looked at titers of vaccine response in, say, pregnant women compared to non-pregnant women. But then, you know, as long as they mount a response, the thought is that it should confer lifelong immunity, and more than 90% of patients should respond to the vaccine. And even if the titers wane over time, you know, we think that there's immunologic memory, that even if the titer is very low, that they're still protected. It's hard, of course, in clinical practice if we see someone with an undetectable titer to say, oh, I'm sure you have immunologic memory, I won't revaccinate. So, you know, we would tend to revaccinate in that context, but it is a pretty potent vaccine. And actually there's a new vaccine, Heplisav, which is just 2 doses 1 month apart, which is thought to be even more effective. It's not approved for use during pregnancy, but it is available now.
I have a question about you mentioned something about possibility of some vaccine failure due to the opioid epidemic.
Yeah.
Do you think there's a real signal there, and
Yes.
maybe the new vaccine might be better?
Yeah, no, I think that's a really, really good question. You know, when we looked at the Quest data, we tried to also divide our population based on those that would have benefited from birth dose vaccination and not, and we still saw rates of hepatitis B in patients who supposedly were vaccinated at birth. That being said, we don't know how many of them were immigrants, so did they really necessarily, if they were born in after 1981, benefit from vaccination? So it's hard to tell, but you know, the fact that we're seeing a signal in these specifically young patients who presumably were vaccinated at birth suggests that maybe there is vaccine failure, probably in those high-risk patients with repeat exposures and repeat risk. Dr. Dietrich may have.
Yeah, I don't think there's a vaccine failure. I think it's a failure to vaccinate. I think the pediatric guideline came out in 1991 to vaccinate all newborns with hepatitis B. So they vaccinated all newborns as they were being born, but they didn't vaccinate the 16 and 17-year-olds who were about to go off to college and have more likely to be exposed to other viruses than the newborns did. So I see acute hepatitis B in adults, basically, which is sexually transmitted, you know, clearly not from the opioid epidemic, and I have been for years, and anybody who's was born before 1991.
Right.
It's frequently a post-divorce hepatitis B. But,
It has an abbreviation, PD.